Very good afternoon to everybody. Before we start the third session, I would like to start it with a small prayer. Om Namami Dhanvantarim Adidevam Sura Surair Vandita Pada Padmam Loke Jararubhaya Mrutyunasham Dataramisham Vividaushadhina Om Shanti Shanti Shanti. Good afternoon again. I welcome you all to the third session of Shalya Tantra, that is the Bhagna session conducted under Tadvidya Sambhasha. So in the last sessions, without wasting much time, I would like to start off with the current session. So in the previous sessions, we had seen an introduction to the anatomy and physiology of the bone. In the second session, we had seen the various classification of fractures. Now, in today's session, we were left behind with what the pathological fractures were. The pathological fractures are in the previous session. So today we'll be seeing what the pathological fractures are, and later, if time permits, we will also be completing with the joint disorders, that is the dislocation and subluxation. So to start off with, so today we'll be starting off with what is called as pathological fractures. So we know that pathological fractures is one that it is a subclassification under the classification of fractures because of etiology. Now, as the name suggests, we all know that pathological fractures are those wherein the bone is weakened priorly. The bone is weakened because of what? Because of any disease or pathology. It is weakened because of a disease or pathology, and in such a case, even if a small amount of trivial force is applied, then it renders the bone to fracture. So this is called as pathological fracture. So under the heading, we also saw that one of the main causes for pathological fracture is to occur is osteoporosis. Now, even in this case, which are the bones or the skeletal apparatus which are more prone to get, to end up with pathological fractures? So, under this, first one is, we have the vertebral column. And even in this, more prone is the thoracic and lumbar vertebrae. And next comes fracture of neck of femur. So fracture of neck of femur. And the third one is Cole's fracture. So these are these two important fractures, and fractures of basically the thoracic and lumbar vertebrae due to osteoporosis is the most commonly seen pathological fracture because of osteoporosis. What is fracture of neck of femur? When we deal with the fracture with respect to that of femur, we will be dealing in detail with respect to the fracture of neck of femur. Cole's fracture, we had seen it in the last class, wherein it is the fracture at the cortico-cancellous junction of the distal end of the radius. Thing to be remembered is CD, that is with a dorsal tilt. So Smith's fracture is that which is with a ventral tilt. So both of these happen at the cortico-cancellous junction of the radius. So with respect to the pathological fracture, this is the main cause, and now we saw the definition of pathological fracture, and which is the main cause because of which bones usually end up with pathological fracture. After this, now we will be seeing what is the classification of pathological fractures. Okay, now we will see the classification pathological fracture and its classification. So it is classified into two, that is based on the etiology. So the first is localized disease, and the next is a generalized one. Okay, so under localized disease, the mnemonic is NINM. So what does NINM stands for? N stands for neoplastic lesions. So under that you have benign and malignant. So the under the classification of fractures, the first is that because of localized disease pathologies. Under that we have three categories. So first is NIN, that is NIM. Under N you have N for neoplastic lesions. Under that we have the benign and malignant. So we will be seeing minimum of one example under all of these. I think that will be sufficient. So for benign we can have giant cell tumor. For malignant, it could be Ewing's tumor or osteosarcoma. Okay, next, this is N. So this is what is N. Next we go for I. I refers to inflammatory conditions. I stands for inflammatory conditions. So to quote examples under this, you can have examples like pyogenic, osteomyelitis, or tubercular osteomyelitis. Now, osteomyelitis itself is a big chapter which we will be seeing in further classes. We will go into the depth of osteomyelitis later. Right now, for example, what is the localized disease under the inflammatory condition that could, render the bone to pathological fracture? We have the examples of, it could be a pyogenic osteomyelitis or a tubercular osteomyelitis or a tubercular osteomyelitis. Next is M for, write it here, M for miscellaneous conditions. So under this we can have an example of simple bone cyst or an aneurysmal bone cyst. So this is the classification under localized. So you have NIM, N for neoplastic lesions. Under neoplastic lesions you can get benign and malignant. Under benign, for example, we have the giant cell tumor, and for the malignant we have the Ewing's tumor or the osteosarcoma. Under inflammatory conditions, we have the examples of pyogenic osteomyelitis or tubercular osteomyelitis. Next, under the miscellaneous category, we have a simple bone cyst or an aneurysmal bone cyst. Now, moving further to the generalized classification. Moving further to the generalized classification, it can be taken as H, A and M. So I'll write it. This is NIM and this is HAM. So H stands for hereditary reasons. A for that is diseases. This is acquired. And here again we have the miscellaneous group. So under each of this, under hereditary, you can have osteoporosis. So osteoporosis stands under both acquired and hereditary. So one cause. Under hereditary, you could also have osteogenesis imperfecta. Okay, so under acquired, the other reasons could be rickets, osteomalacia. So under miscellaneous causes, we can include the Paget's disease. So under miscellaneous causes, we could include the Paget's disease. So here, under the generalized category, we have H, A and N. So under H, we have the hereditary diseases. A for acquired, N for miscellaneous. Under this, examples of osteoporosis and osteogenesis imperfecta. Under acquired lesions, we have osteoporosis, rickets, osteomalacia. Under miscellaneous, it's Paget's disease. So here we are learning only few examples under each of the heading. There are actually more number of disease pathologies that can render the bone to a pathological fracture. Now further moving on to, now we saw what the definition of pathological fracture is and the etiology, then the classification based on the etiology. So what are the diseases, the localized diseases and the generalized diseases that causes pathological fracture is what we have seen. Now going to the diagnostic aspect of it. How do you diagnose a pathological fracture? So this more of, so we can see Prashna and Anumana in this category. So usually it goes along with the questions. So one thing what is when you question the patient that how the fracture occurred, and if he says that there was a significant history of trauma. So if there is fracture without significant history of trauma, then you have to suspect that it is pathological fracture. So that is the first thing. Another thing is, suppose you question the patient and he says, like just prior to the the fracture to occur, the pathological fracture to occur in the body, if the patient says he experienced certain kind of discomfort, so if he says he experienced certain kind of discomfort in the region, so that also it throws light on, you have to think about a pathological fracture. Another very evident on the questioning is, suppose like on questioning you get to know that patient is a known case of any CA, then obviously you can think of your Anumana should be that it could have a bone metastasis. So because of which the bone has rendered finally into a pathological fracture. So this is how you diagnose. Obviously, radiological investigations can be done, but basically, clinically, how you diagnose a pathological fracture is through this questionnaire. Now, moving on to the treatment. So the first thing is treatment. First thing under treatment is you have to inquire or you have to assess what could be the pathological reason behind. So what is the disease or what is the pathology behind it? That has to be assessed and that has to be treated. Alongside, the next is you have to make an assessment on how well could the fracture go into healing. Because one thing what we saw during the classification of fractures because of etiology under the traumatic and pathological classifications, we saw that usually most of the pathological fractures end up in non-union. So that is why it is very important, based on the etiology and based on the assessment, based on the reasons, you have to make an assessment as to how better could this fracture move towards healing with the normal conventional methods of fracture treatment. So that forms the basis. The next is few examples. What we have to know is, now suppose it is a general the pathological fracture is because of certain generalized conditions, like for example osteogenesis imperfecta. So and you have a Paget's disease. So all these usually you can predict the outcome. The outcome is predictable. The outcome is predictable, and that too it is with the usual conventional method of fracture treatment. With the usual conventional treatment, you can predict how long will the fracture take time to heal. Suppose it is in a case of bone cyst, pathological fracture because of a bone cyst. Usually, because of this, it is delayed. It is delayed than the prior condition. Suppose now you are treating a bone is rendered to pathological fracture, and the bone has a history, and the person has a history of being supposed, or it is infected with osteomyelitis, or the pathology is of osteomyelitic bone. So this takes even more. It is even more delayed. Usually it takes years together, and even in spite of good treatment procedures, it could fail to unite. So this is in case of osteomyelitic bone. Suppose in case of a metastatic bone, the outcome is even more unpredictable. The outcome is even more unpredictable. So this is in case of a metastatic bone. So based on all these reasons, so our treatment plan should first also include an assessment of how could this bone move towards healing. So this is one example. Suppose with all the conventional methods, few of the interventional methods what you could go for surgical method is that one is bone grafting. So what is bone grafting? Bone grafting is where the bone tissue is taken from some other part of the body. So it could be an autogenous species and allogenous. Autogenous is from the person's own body. Autogenous is from a different body but of the same species. Xenograft is autograft, allograft and xenograft it is called. Xenograft is from a different species. Usually it is a bovine species that is used. So what happens? In the process of bone graft, they use the bone tissue to fill the gaps. Suppose you have, non-union here and there's a huge gap here. So in such cases, when you place the bone graft, it will have a osteogenic action. So that will help in, stimulating the union process. So that is why one thing what we could go is for bone grafting. That is, it has an osteogenic action. Another main important thing is that why we could go for surgical intervention. One is to initiate the osteogenic process. The second one is to make the patient ambulatory. So these are the two aims of surgical interventions for a pathological fracture. Now with this, we end with the pathological fractures. In the last session, before starting the session, we saw that suppose a musculoskeletal injury happens in the body, what are the different tissues Now, suppose a musculoskeletal injury happens in the body. We saw that what are the different tissues that could, be injured. So we saw that it was the bone tissue, it could be the muscles, it could be the ligaments, the neurovascular bundle, everything comes into picture. The joint also comes into the picture. Now, injury to the joint is another most important. Now, under the injury to bone tissue, we saw the fracture classification, different types of fractures and pathological fracture. Now, coming to the injury to the bone, injury to the joint, now it itself is another very main chapter that deals with dislocation and subluxations. So that I would like to keep it at the end of this session so that we could, if possible, we can just complete the chapter of dislocation and subluxation. Now, the next entity that comes into picture when musculoskeletal injury happens is, that is injury to ligament. So we will be seeing in very short about injury to ligament, muscles and tendons and not dealing with the depth of it. So one thing what we have to know is injury to the ligament is called as sprain, whereas that of the muscles and tendons is called as strain. Okay. Now, the injury to ligament or the sprain can be classified into three. That is 3 degrees actually. So that is the first degree, second degree and the third degree. Now suppose, what is a ligament? It is a thick fibrous tissue that connects bone to bone. So ligament connection is bone to bone, whereas a tendon is between muscle and bone. I hope this is clear to everybody. So what happens? Suppose now this is a Suppose now this is a ligament. So in first degree what happens? So in first degree only few fibers of it is, I'll depict it in blue, only few fibers of it are cut. Suppose what happens in the second degree, almost, in the second degree we have almost, 1/3 of it being injured. But in third degree what happens? All the entire length is injured. So this is first degree, this is second degree, and this is third degree. So this is the basic classification between between the degree of tear of the ligament in first, second, and third degree. Now, obviously, it is a traumatic lesion. It could be because of a fall. Usual etiology is traumatic. What happens here is, now coming to the classification, coming to the clinical features. So it could be mainly it is STD or SPD. S stands for swelling. Okay. T is tenderness or pain, and D for disability. Okay. So obviously it is greater. In second degree it is greater than the first degree. So in the first degree you could have minimum amount of, in the first degree all of these are minimum amount of swelling, tenderness and pain at the site wherever there is a ligament tear. So in the second degree it is more in the scale than that of the first degree. So the swelling is more, the tenderness or pain is more, and even the disability, because of the pain you cannot use whichever is the ligament affected, that portion is affected, so you are not able to move the limb of that place. So that is why there is disability. It is more. Even in third degree the same thing is there. There is swelling, there is tenderness and disability. One thing what we have to see is, so it is quite astonishing also that in third degree usually pain is a little less than compared to the second degree. So this is what we have to see. Now moving to how actually a ligament tears. Now we saw this was just a pictorial representation on how, what is first degree called, why it is second degree, why it is third degree based on the number of fibers or the thickness of the ligament that is being injured. So in first degree it is just 2 to 3 strands, in second degree it is almost 1/3, and in the third degree it is almost the full length or the full thickness of the ligament that is injured. Now coming to the pathology of how a ligament can be injured. Now suppose this is one bone, okay, and this is one bone. Now suppose this is the ligament. So one way how a ligament could tear is because of the trauma. It could tear within its substance. So this is one lesion. So there is a trauma here. So this is one type. Another type is where, in the process of getting torn, so the ligament is being ripped off the articular surface of the bony surface, and in the process what happens, a piece of bone also gets avulsed. So these are the two ways how a ligament could tear. So this involves a lot of pain, the tenderness, whatever the clinical features we saw, this could be enhanced in this case because a piece of bone is also chipped away along with the pull or the tension of force of the ligament that is attached to the articular surface or the bony surface. So these are the two ways. So first is it could break, the ligament could be injured within the substance of it, or during the process the ligament could be torn off the articular surface or the bony surface, during which it also avulses a bony fragment along with it. So this is spraying along with avulsion. So this is the main mode of pathology of spray. Coming to the diagnosis, first is obviously the thing what could be assessed in second and third degree spraying is there is something called as stress test for specific joint. Like You have the varus test for the knee joint. You have the anterior drawer test for the ankle joint. So it varies according to the joint. We need not go into the depth of it. So what basically stress test is based on the history, and whichever is the ligament of question which you have to subject to examination, it is a maneuver wherein the examiner, he exerts pressure over the ligament. So whichever is the ligament that is injured, so he exerts pressure over the ligament, because of which there is pain. So in first and second degree, especially in second degree, pain increases, but in third degree, you can feel, the joint to open up. So it is called as open up. So in the third degree, during the examination, you can feel that the joint opens up. So this is a stress test. But if you have to go for a radiological investigation, you could go for X-ray or an arthroscopy. So in conditions where you cannot diagnose, and even an MRI is done to diagnose, so these are the investigatory methods, whereas stress test is that which is a clinical signifier of the same. Now this was about sprain. Yeah, dealing with respect to the treatment, again, first of all, first degree, it almost requires no treatment. The patient will come back to normalcy within a couple of days. You even need no immobilization is required in case of first degree. Third degree is usually a surgical repair. Third degree always usually demands for a surgical repair, but in case of second degree, you have to go for immobilization, like it ranges up to 4 to 6 weeks, along with, you're not supposed to no weight bearing up to 3 months. So no weight bearing up to 3 months. So this is the treatment aspect for sprain. So we saw what sprain is, what are the degrees of sprain, how it is classified, what is the classical features of sprain, and then we saw the pathology of sprain, how the ligament tears, and then we saw treatment principles for sprain. So this is in short about sprain. Now the next thing to get affected or injured during a musculoskeletal injury is the muscle and the tendon, which is called as strain, as we previously saw. So here, so usually there's a tendency for the muscle to get injured than the tendon is more in young, whereas it is opposite in elderly people. So this is one thing what we have to keep in mind that could help us in diagnosing with history. So usually a muscle tear goes, younger generation are more prone for a muscle tear. Now why does there will be a tear in the muscle or tendon is, suppose the muscle is in rest, so certain portion of muscle is still in rest, and then you subject it to overstretching. So then what happens? It results in strain. That is, the muscle fibers get injured. Another thing is, suppose the muscle is in contraction and during that process you go for overstretching that portion of the muscle. So even in that case, it ends up in a strain. So this you can make out while you're exercising, while you're doing yoga, with an intention to gain the maximum flexibility or the stretch. People could go beyond their limits, their anatomical limits in attaining. So in such cases you could end up with a muscle injury. So this is the basic of a strain. We need not go into the depth. What is the treatment aspect of it? Usually it needs an end-to-end repair. So it is a surgical intervention. You need to maintain the continuity between the muscle fiber with an end-to-end repair is the prime basic treatment principle for a strain. So with little amount of immobilization. Suppose even after that you are not able to gain good results, then we could go for a tendon grafting. So tendon grafting is also done just like bone grafting. So this is done in cases of failure of the initial surgical intervention. So with this, we completed the injuries to the bone tissue, that is the types of fracture, detailed explanation of fracture with respect to each and every bone. The main bones, that is the humerus and the femur, first we will cover. So that we'll be doing it in further classes. But in basics, the classification of fractures. Then we saw the other tissues that got injured, that gets injured, that is the tendons. We saw sprain, what is sprain and what is strain, what pathological fractures are. Now we will deal in detail with another important part, that is the injury to joints. So we know that during a musculoskeletal injury, it is not just the bone tissue that gets injured, but it is also during the same injury that it could also render the joint diseased. So what happens in the injury to the joints? Now, basic to injury to the joints are the dislocation and the subluxation. But before we go into the depth, it is very, very important for us to know the relevant anatomy of any joint. That is, for a joint, what are the factors that keeps the stability of the joint in picture, so that when that is hampered, why the stability of the joint vanishes, leading to the injury of the joint, that is either the dislocation or the subluxation. So in that, we have three main entities that contribute to the joint stability or to the integrity of the joint. So what are they? First is the joint design, we could call, or the structure of the joint. That is the first thing. Next is joint design, or you can call it as the shape of the joint, shape of joint. Next important is ligaments, and next important is the muscles. Okay, now we will see why each of these things is important that contributes to the joint stability. So first is the joint design. Now we know that each and every joint has its own design. Suppose, for example, to see the stability, we all can take the example of the joint, the hip joint. Now what we know is, in the hip joint, we have the acetabulum cavity. Suppose, for example, of hip joint, you have the acetabulum cavity and you have the a fully ball-shaped end of the proximal end of femur. So now we know that within the glenoid cavity, almost the entire proximal end of the head of the femur sits within the place. So now, shall we compare the same joint with that of the shoulder joint? So in shoulder joint, what happens? We have the glenoid cavity and it is much shallower. The cavity itself is shallow, whereas here it is a deep cavity, acetabulum cavity. It is a shallow cavity, the glenoid cavity. Whereas the head of the humerus is more bigger than the depth of the glenoid cavity. So when we compare to the design of the interior design of the integrity of between the hip joint and the shoulder joint, obviously we can say that with any amount of trauma, whatever the traumatic force may be, we know that shoulder joint is more prone for dislocation. So this is just an example of how a joint design or the shape of the joint contributes to the whatever with respect to shape of the joint, we can decide how more prone a particular joint could be to end up with either dislocation or subluxation. Next is ligaments. So now we finished with the joint design, that is the shape of the joint, with an example of the hip joint and the shoulder joint, wherein we saw that shoulder joint is more prone to dislocations or subluxations than the hip joint. Now coming to the ligaments. Now what happens? Now we have already seen that, ligaments holds. It is the fibers that runs between bones to bones. So ligaments have certain function that it will not let any joint to move unnecessarily. That is, to displace from its anatomical situ unnecessarily. So it holds the joint in its place in the anatomical position. So this is the function of the ligament. So that is why it is also called as static stabilizers. Why? Because of the ligament, it will prevent any abnormal mobility. It prevents abnormal mobility of the joint. That is why it is called as static stabilizers. Now suppose an ligament is injured, what could happen? That we will see that in further when we deal with the in the depth of dislocation and subluxation. So as of now, when the ligament is injured, the stability of the integrity of joint is also lost. So that is how the ligaments contribute to the joint. The last comes the muscles. Now what the muscles does? Now we know the examples of the rotatory cuff. As such, around the joint, you have a tight muscle layer which helps to keep the joint again. It prevents any abnormal mobility of the joint. Along with that, what muscles does? So you have a tendon that is attached to a bone. So you have a muscular covering. Now suppose there is an external force. What these muscles does? It will go into contraction. So it goes to contraction and thereby it prevents the underlying tendon tissue by being injured itself. So what it does, it also gives you a protective action. So that is why muscles are called as dynamic stabilizers. Dynamic stabilizers of bone. So with all the three of this, a joint integrity is maintained. So it is maintained by the shape of the joint, or it influences the integrity, the joint shape. Next comes the ligaments which are called as static stabilizers. Then we have the muscles which are called as dynamic stabilizers of the bone. We saw the reasons why they are called so. Now, with this, we will further move on to what are the injuries to the joint that could happen if these three are hampered or if these three are injured. So now, the injury to the joints, it includes subluxation and dislocation. So we have subluxation and dislocation with respect to the joints. Now, what does subluxation mean and what does dislocation mean? So first, I will be showing subluxation. So this is one part of the bone and this is another articular part of the bone. This is normal. Now, suppose there is an injury. So in this case, so this is the contact. So in this case, suppose here, it is called a subluxation wherein there is joint displacement but there is partial contact, but a little contact between the articular surface is still maintained. In such cases, what is it called? In such cases, it is called as subluxation. I repeat, during an injury, when there is, the joint is displaced, but it maintains a certain amount of contact between the articular surfaces. In such cases, it is called as subluxation. Now, what is dislocation? It is simple. From the normal, suppose you have an injury wherein the two articular surfaces are in no longer contact but are displaced far away, then it is called as dislocation. So this is the basic for defining subluxation and dislocation. A simple definition to define both of them. Now we will see the types. So usually there is no, the classification is meant in detail for dislocations and subluxations and it is taken under the same heading. So what are the two reasons? So we have here, it is congenital, and the next one is acquired. Under acquired, you have traumatic and we have pathological. So almost all the classifications are same, except that how they are framed is only the difference. So here under congenital, you have one, the basic example, the famous example is congenital hip dislocation. So CHD is what? That is, the baby is born along with dislocation. So birth happens with dislocation, and CHD is an example, that is congenital hip dislocation. So this is the example for congenital. Now going to the acquired, as the name suggests, traumatic is where the dislocation occurs because of an external trauma, suppose a fall. So may of the dislocation because of this external, that is the traumatic reason. The next is the pathological. Again here, as it means, pathological means the joint is rendered to a pathological weak because of an underlying pathological condition, because of which the joint renders or the joint ends up in a subluxation or a dislocation. Now moving further, we will see the types of traumatic dislocation. Because among all of this, traumatic dislocation is the most common. So that is dealt in detail again. So now we see traumatic dislocation. So for this we have a mnemonic which we can remember as at our refracture. At our refracture. Okay. So what is at? It stands for acute traumatic. OUR stands for old one second. Unreduced dislocation. Next is RE. Recurrent dislocation, and this is dislocation with fracture. These are the four main classifications of traumatic dislocation. Keep in mind, this is the classification of basic classification of dislocation or subluxation. Under that we have traumatic dislocation, and most of the dislocations commonly seen are traumatic dislocation. So these four classifications are under traumatic dislocation. So first you have acute traumatic dislocation. The next is old unreduced, and third is recurrent. The fourth is dislocation with fracture. So as the name says, first is acute traumatic dislocation. So suppose you have a fall. Suppose because of fall, there is an acute episode of dislocation. For example, dislocation of shoulder joint. So this is acute traumatic dislocation. Next is old unreduced dislocation. So it is an old case. So when it is getting presented to you, it is unreduced. It is not rendered to treatment. So such a dislocation is called as old unreduced dislocation. Usually what happens, an example is for this is posterior dislocation of hip. Okay. Next is recurrent dislocation. What does that mean as the word says? Now suppose there is an episode of dislocation, first episode of dislocation. Whatever is the treatment given to you, it is not satisfactory for complete healing of the joint. So what happens the next time? The joint stability gets decreased. The stability of the joint gets decreased, and another time, even with a trivial force or a simple fall, the joint will end up with recurrent dislocation. So the same joint which was treated priorly for an episode of dislocation renders itself into another episode of dislocation is what called as recurrent dislocation. The next one is fracture dislocation. That is any dislocation that happens along with a fracture. So suppose there is a fall, you also have suppose for example you're falling on your upper limb where there is a dislocation of shoulder joint. Along with that, you could also end up with a fracture of the shaft of humerus or the fracture of the clavicle bone. So that is called as dislocation with fracture. So after this comes the clinical features. So what are the main clinical features you have to assess? One thing is that any dislocation is the clinical features are strikingly expressive. So assessment at the clinical level makes the major part of diagnosis. So the first thing what we have to look for is pain. So all dislocations are very painful. So all the dislocations are very painful. So that is first. Again, the same thing goes SPD. Instead of that, you can go for or STD. So you have pain, swelling is also evident in dislocations. Then disability is also, you are not able to move that particular joint. So why disability? First thing is you have a lot of pain. Second thing is articulation is lost. And the third thing is, because of the pain and because of the injury, the surrounding muscles goes into spasm. So because of all these three things, you are unable, the part or the joint ends up in disability. Now after that comes, I'll be writing it here. The next clinical feature is loss of movement. Loss of movement and disability is almost the same. So you have loss of movement. After that is pain, swelling, disability, and loss of movement. So these are the main clinical features that comes into picture with any dislocation. Now after this, now we saw how the pathology of strain, that is how actually it would be with loss of movement. Another important clinical feature is length, shortening of the limb except for anterior dislocation of the fracture. Now we will move on to the mode of pathology for how a joint, it dislocates. So now suppose this is the joint, this is the articular surface. So because of a fall, in first case, what could happen is, there could be a break here in the articular surface, in the articular cartilage, and one of the articular surface could escape out through the rent that is created here. So it could be that the bone becomes like this. So it is, the side is intact. Here it is two piece. So here through this piece, so whichever is the rent created here, one articular surface has penetrated through it. It has moved through the rim created here. So one could be that how a dislocation could happen. Now the second one is the articular surface. Now this is it. Here another thing that could happen is there could be a tear here, so that whatever is the connection between the articulation, that could be just pulled off. There could not be a tear within its substance. It is just pulled off from its connection or from its, from the place where it was giving an articular stability. This is another second mode. So this is first. The third one is exactly the same way. That is because it could be how we saw for a ligament tear. So this is the third variety. So obviously when the articular cartilage or the ligament is, injured, the joint stability goes down, because what we saw is ligament is one of the static stabilizers for any joint integrity. So this is the third variety. Now another fourth variety what we have to see is again what we saw in case of ligament tear, that is the third variety, wherein there is ligament tear along with avulsion of a piece of fracture. So this is the fourth pathological variety, how a joint could render into subluxation or dislocation. So the first variety is there could be a tear and one of the articular surface can move through the space what it is found. The second one is whatever is the articular ligament or the cartilage that is getting attached here, it could just move off from the site of its insertion or from the space where it was giving the stability. The third one is there could be a simple tear through the entire substance of the ligament. The fourth one is when the supporting structure is moving away, it could chip a piece, it could avulse a piece of bone along with it because of the tension force. Now, we have another very important thing what is called as osteochondral fragment. So what happens here is that now usually during dislocation, the two articular surfaces come in contact during the when the dislocation happens during the act. So in such a case, what could happen is that the two articular surface could rub each other with a piece of articular cartilage along with it that lies freely in the joint space, that could lie freely in the joint space. So this is very important because sometimes even after the joint is reduced, this, if it is unnoticed, this osteochondral fragment could again render problems in further days. So that is why when you are taking a radiological examination or X-ray study, look for a fracture dislocation, the diagnosis for fracture dislocation and the diagnosis to look for an osteochondral fragment is very, very important, because if this goes unnoticed and the osteochondral fragment remains inside, it could render problem again, even if the joint gets, stabilized with treatment. So that is one important thing. So until now we saw what are the different classifications, the traumatic classifications of dislocations, and what are the clinical features of dislocations, the clinical features helps us to diagnose, and what are the pathological variations, how a dislocation or subluxations happen. Now with respect to radiology, what radiological investigations, so you can go with X-rays. So one thing to keep in mind is it shouldn't be in a single view, always you have to have a two-plane view of the X-ray. Another very important thing is to look for fracture and osteochondral fragments when you are diagnosing for a dislocation. Now we move for the last two things what we are left is with, this general complications and basic treatment aspects for dislocation. Among these, we have to keep in mind the osteochondral fragment and also the avulsion fracture, because these two are explained when we further move to the Bhagna aspect. That's the Ayurvedic aspect of fracture. When we deal with Bhagna, these two are important. So suppose we have a previous review on this topic, it's very easy to understand what Acharya Sushruta is trying to convey to us. Now the last two things are the complications. So complications, one thing we have already seen in the traumatic classification, that is recurrence. So it itself is a complication of any dislocation. Recurrence is a complication. The second one is decrease in joint stability is the next complication. The third one could be joint stiffness. Okay, it renders the joint to stiffness. Fourth one is the joint is more prone to end up with the pathology of osteoarthritis. And another very important, especially in case of dislocation of neck of femur, it is avascular necrosis. It is avascular necrosis. So these are the major 5 complications of any dislocation. Now, looking on to the treatment aspect of it, we will, with respect to the traumatic dislocations, the first is acute traumatic dislocation. So in case of acute traumatic dislocation, first gold standard treatment is to reduce the joint so that the joint is rendered to stability. So first prime importance in dislocation is to reduce to the proper anatomical situ. So with this can be done in two ways. One is the conservative way and one is the surgical way. Usually conservative way is done with external maneuvers, manipulative maneuvers, external manipulative maneuvers. Now it is because of this what every orthopedician is applauded for, because this is the major to externally manipulate and reduce the dislocation of a joint. So the two joints into the anatomical situ. So external maneuvers comes under the conservative. So surgical is when you go for an interventional method, when usually the external maneuvers fail. So in such cases you go for a surgical intervention. Next is surgical intervention is also done in case of, so first is when this fails, and next suppose you have fracture dislocation, one of the varieties classification of dislocation what we saw, and even in that case you go for a surgical intervention. Now the next thing is recurrent dislocation. So what do you do for recurrent dislocation? Every new episode is treated as a acute traumatic dislocation. So every new episode is treated as an acute traumatic dislocation, but you have to also see that you enhance the stability of the joint. Enhance the stability of joint. So this is one important thing in case of recurrent dislocations. So next was fracture dislocation. With fracture dislocation, we saw that it has to go for a surgical intervention. So even old unreduced dislocation also it needs an surgical intervention. So it also needs a surgical intervention. So this is just the basic treatment principles on how we treat the dislocations. So with this, today we saw what pathological fractures are, and we saw how it can be diagnosed and what is the treatment methods for pathological fractures. And next we saw what the other entities that come into the picture when there is a musculoskeletal injury. So that is injury to the ligaments, that is sprain, 3 degrees of sprain, the first, second and third degree. What are the pathological variations of sprain, what strain means, how it is treated. Next we moved on further to injury to the joints. Under that we saw what are the three main factors that help in the joint stability and what are they called as, how they contribute to the joint integrity. After that we saw the basic classification of joint disorder or joint injury, that is dislocation and subluxation. We saw the main heading or the main classification as congenital and acquired. In acquired we saw the traumatic and the pathological. One thing, yes, I forgot about the pathological fracture is that, so same like that of pathological fracture, in case of pathological dislocation, the joint area is rendered diseased because of a pathology already existing in the body. So main thing is, suppose in case of septic arthritis of the hip joint, usually there is chances of it ends up with dislocation of the hip joint. So is usually a common complication of septic arthritis of hip joint. So that is one example to quote. And next we saw the 4 classifications of traumatic dislocations. Then we saw how the pathological variations are, how a dislocation or a subluxation could occur in our body, the basic 5 complications, and the general basic treatment principles that we have to take to treat the dislocations and subluxations. So with that we finished the modern part of dislocation and subluxation along with the basic introduction to fractures, the types of fractures. So in the next class we will take up Sandhi Moksha or Sandhi Mukta Bhagna classification given by Acharya Sushruta, and after that slowly we will move into the Khanda Bhagna part and taking up examples of individual fractures as per the syllabus. The most important, the humerus and the femur dealt first, and the rest will follow next in pace. So with this, I would like to end today's session again with a prayer. Om Gnananandamayam Devam Nirmalaspatikakritim Adharam Sarva Vidyanam Hayagrivam Upasmahe. Om Shanti Shanti Shanti. Thank you. We will meet again on Wednesday between 3 to 4 p.m. with the next session, that is session 4 on Bhagna. Thank you.